much, sir, for this opportunity. Thank all the people who have come here, to learn. I'm sure it will be useful. In the next 10 minutes, I'll convey to you some important aspects of retinoscopy. Ultimately, the foundation of an eye hospital or an eye clinic is to give the best vision. You all agree? And the most important is the optometrist and the refractionist, and you must know what they are doing. So I'll skip off all this and just talk about the refractive status. So you can assess subjectively or objectively. More important would be to find out exactly by objective method. One of that would be retinoscopy. This is the father of retinoscopy, Ferdinand Quignett. He started it in 1873. In retinoscopy, it's otherwise called skioscopy. When light is reflected from a mirror, or now we use the self-illuminating retinoscopes to find out how it works and where the image falls for us to find out what is the power. Three stages. First is the illumination of the retina, then the reflex, and where it is getting projected. That will determine how it is. So what we use is the Welsh-Shallin model of self-illuminating retinoscope. You keep the sleeve down, only it is a plain mirror. If you put it up, it becomes a concave mirror. Reflexes will change. Concave mirror is only meant for high myopic powers. Otherwise, by default, you use only the plane mirror. Dry is without a cycloplegic, wet is with cycloplegic. And if the patient is looking far away and you do without a cycloplegic, it's called static. If they are looking into the light, it's called dynamic. So the working distance is ideally 2/3 of a meter, which is the arm's distance, and the 1 meter is for practically to calculate during your learning stages. Now this is a model eye where you can practice. Here you can see how the reflex is moving. You can see beautifully the reflex moving with the movement. Now there are a lot of things. If the speed is faster, you are closer to the neutralizing point. If it is brighter, you are closer to the neutralizing point. Then like that, and the width become narrower and crisper when you come to the neutralizing point. We will not talk about this, you understand this. Only when the image falls between the patient and the observer, it will be against reflex. If it falls at the observer, it is a neutralization point. Everywhere else it will be with the movement. You go through, I think it will come in the notes also. Here you can see with the movement, against movement, and neutralization point. Now here you can see clearly, what do you see? With or against? Pardon? Yeah, you can see very clearly it is with. Now you are seeing what? So this you try in the model eye. Don't sit in front of a real patient and try for half an hour. You learn and then you can go into the patient. So these are the two important movements. So what are the signs of neutralization? The whole pupil will be filled, no movement, and when you put additional 0.25, either it will get reversed, positive will, with will become against will become with. These are the simple things. Now I will go straight away. See, for a oblique astigmatism, which is not 90, 180, three things are there. This is called the break. Three beams, no, one on the iris, one in the pupil, one. It will not be straight. It is called break. And here, there is a width. If they are away from it, it will be wider. If it is in the same axis, it will become narrower. Intensity will be brighter, and skewing. I'll show you what is skewing. Here you can see one will move in one axis, the other. It doesn't move parallelly. This is called skewing. And then just like your Jackson cross cylinder, you move 45 degrees on either side and see. This is to confirm the axis. Difficulty, all difficulties are the most important was the scissors reflex, where you can see the scissorsing. Can you see? One is moving with, the other is moving against like a scissor. This is the scissorsing reflex of a keratoconus. Drug correction you give for only spheres. Exceptions are mixed astigmatism, pseudophakia, aphakia, and presbyopic. Wherever there is no accommodation, we don't give at all. Never give for minus spheres or cylinders. Now I will come to this is again minus at 180 and plus at 90 with the rule. Opposite is against rule. These are the basic things. So we will teach normally 8 steps of retinoscopy. This is what you get out of your retinoscopy. This is called power cross or the retinoscopy value. 90 degrees it is 30.5 and 180 it is 2.5. Then what do? You sit at a distance of 1 meter, then you make a correction of minus 1. Plus 3.5 becomes plus 2.5. 2.5 becomes, this is the distance correction. Supposing minus 3.5, you put minus 1, it will become minus 4.5. Just remember that. So this is the first step, second step. Third step is this distance correction. Then you call it subjective. What do you take? take the smaller power as the spherical power. So here we have taken 1.5 as the spherical power, and I have got 1.5 all around, that is the spherical power, but I need to get 2.5 at 90. So I will give, it will act in the opposite axis. I will give a plus 1 at 180. So it will become plus 2.5 at 90. So this is the, okay, subjective value. Now what is the idea? Both are equal powers, but the minus cylinder is better acceptable than a plus cylinder. So what will you, how will you transpose? Add both, plus 1.5 and plus 1 is equal to plus 2.5, and reverse the sign and the axis. It will become minus 1 at 90. This is a simple spherocylindrical transposition. Okay. Now I have got a same power with a minus cylinder. Now what did we use? Do we have drag correction? Nil. Age is also more, and we have no drag correction. Near vision, for the age we have to give age corrected. At 40 you give 1.5 at 45, like that we go. That is age corrected. But for a watchmaker or a goldsmith, we do the scientific method of drag correction, near vision correction. So this is the transpose, plus 2.5 minus 1, 90.66, and add 1 plus 3. This is how you write the prescription. Don't just write plus 1 add. No, you write this properly. Now what will be the diagnosis? Quick, 15 seconds. Anybody? What's the diagnosis? How many of you want to say it's mixed astigmatism? Simple astigmatism. Come on, man. Anybody? Yeah. Okay. This somebody will tell it is mixed because there is one plus sphere minus. Remember, this is a compound hypermetropic astigmatism. Minus at 90 is against rule and presbyopia. These are the 8 steps of refraction. Okay, you got it. I'll just sum it. This is another one. 50 years plus 1.5 and 0.5. Okay. Now what happens to the distance correction? Can anybody tell? 1.5 will become 0.5. And remember, plus 0.5 will become minus 0.5. Okay, plus 0.5 and minus 0.5. Subjective, I have taken a plus 0.5 because I want a minus cylinder. I took plus 0.5. So plus 0.5 is there all around, but I need minus 0.5 at 180. So I have to compromise that plus 0.5. So you add, so minus 1 at 90. By giving minus 1, you compromise that existing spherical and get minus 0.5. Then already you have a minus cylinder. If you transpose, it will be like this. Here it is not necessary to transpose because I want only a minus cylinder. Drag correction will be nil here because it is mixed, and near 50-year-old, near vision 50 years, we are giving an age corrected plus 2. So the glass prescription is like this, and the diagnosis here is a mixed. There you said compound. When the cylindrical power is more than spherical, it is mixed. When the spherical power is more than cylindrical, it is compound. When both are the same, they are called simple. Here if you transpose, you can see that. Okay. So compound is spherical more than cylindrical, mixed is cylindrical more than spherical, and both are equal, it becomes a simple astigmatism. Okay. This is the near vision correction. I have 1 minute. So normally for hypermetropia, you give manifest plus 1/3 of latent. In scientific method for distance, it's also called near vision. So you have to calculate what is available power. You need what power is needed and keep 1/3 reserve. I'll give you an example. Watch mechanic reads at 167. What is his power? 100 by 67, isn't it? So he has a power of 1.5 adapter. To read at 25 centimeter, 100 by 25, I need 4. So normal tendency is 4 minus 1.5, I'll give 2.5, isn't it? But available power, you keep 1/3 reserve. What is that? In 1.5, you keep 0.5 reserve, then I have only effective 1. So I will give a plus 3 adapter power. You go and think. This is the scientific method for giving for your goldsmith or your watchmaker. And these are the ways you can do. These are other examples. And this is, overview of retinoscopy. Thank you so much, sir, once again. Thank you all.
Thank you, Chandra. Very nice